Okay, so today we're going to talk about organophosphate poisoning and how to manage this poisoning. So before we begin, we need to know how these compounds they act and how they produce their effects. So basically, in the neuronal synapses, there is a lot of acetylcholine which acts on these neurons and generates action potential. And at the same time, there is the enzyme acetylcholine esterase, and this enzyme basically it cleaves the acetylcholine into acetyl and choline. The compounds like organophosphates and carbamates, what they do is that they block this enzyme, the acetylcholine esterase, and hence there is an excess of acetylcholine in the neuronal synapses. This excess then keeps on stimulating the neurons, and as a result, the neurons become overstimulated, and it manifests itself as cholinergic effects, which are characteristic of organophosphate poisonings. The symptoms of organophosphate poisonings can be easily classified into acute symptoms, the intermediate syndrome, and the delayed neuropathy. The acute symptoms are usually related with the cholinergic excess, and an easy way to remember all these effects is biomnemonic dumbbells. So, dumbbells is just diarrhea, increased urination, meiosis or pinpoint pupils, bradycardia, bronchoria, that means excessive lung secretions, emesis, increased lacrimation, and excessive salivation. So these side effects are all related to the cholinergic excess. However, it does not encompass all of the effects of organophosphates. CNS toxicity is a very important side effect which is mediated by the nicotinic receptors. And this can be as mild as just muscle fasciculations, or it can lead to CNS depression, anxiety, agitation, and even in worst cases, it can lead into coma and sometimes even convulsions. So other effects of organophosphates, especially on the heart, include heart blocks, it can include arrhythmias, it can include a prolonged QT, and sometimes even MI if there are other predisposing conditions and comorbids. On the lungs, as I explained before, they cause bronchoria that can lead to increased respiratory secretions and hence respiratory insufficiency. And also CNS depression can also lead to aspiration, and neuromuscular weakness again predisposes to aspiration and hence respiratory distress and insufficiency. So that's an important part of the treatment. Other rare manifestations include AKI and sometimes even pancreatitis, but they're not very common. The symptom onset is usually dependent on the mode of intake. It takes around 1 to 3 hours if organophosphates have been ingested, and around 12 hours if they have been inhaled or have been absorbed via the skin. Another presentation of organophosphate toxicity is the intermediate syndrome. So organophosphate compounds are usually lipophilic. That means that they can dissolve into the lipid cells of the body and they get deposited into the fat cells. Hence, they cause a slightly delayed presentation, which is around 1 to 4 days after they have ingestion of the organophosphate. And this usually occurs when the symptoms of acute toxicity have generally resolved. This syndrome presents as muscle weakness, and the most commonly involved muscles are usually the neck muscles, the diaphragm, the accessory muscles of respiration, the intercostal muscles. So the patient usually presents with inability to hold his neck and respiratory distress and respiratory insufficiency. The treatment of this condition is just supportive measures, and it is a self-resolving condition which usually resolves within 2 to 3 weeks in most of the patients. However, the patient may require prolonged periods of mechanical ventilation. Another important presentation of organophosphate toxicity is the delayed and long-term neuropathy. It develops 1 to 4 weeks after the patient has ingested the organophosphate, and this time the mechanism, instead of organophosphates targeting the cholinergic neurons, is thought to be because they target the neuropathy target esterase enzyme. This enzyme is found in the central nervous system, in the peripheral nervous system, and in the muscle cells. So the patient presents with a very painful glove and stocking like neuropathy, and there may be associated ascending flaccid paralysis, and there's some cranial nerve abnormalities may also be seen. The diagnosis is made on the basis of NCS and EMG, and we don't really know why some patients go into this delayed neuropathy. Some studies suggest that it's because the patients get a lower dose or a delayed dose of pralidoxime, but the exact mechanism or the exact cause is not really known. Mild cases of the neuropathy resolve on their own in some time. However, some patients go on to develop a more permanent kind of a disability. It's more of an upper motor neuron syndrome with lower limb spasticity, leading to permanent disability. Why this happens in some patients is not really known, and it has nothing to do with the dose of organophosphate taken. Some patients who survive the axonal neuropathy, they actually develop neurobehavioral symptoms as well, which may be related to memory, abstraction of ideas, and even symptoms of Parkinsonism. The diagnosis of organophosphate poisoning is largely clinically based according to the history, the signs and symptoms, and the general physical examination. RBC cholinesterase levels can be measured, and they can give you an idea of the extent of the toxicity and can also guide therapy, that they can tell if pralidoxime is working or not. Plasma acetylcholinesterase levels, on the other hand, are not very effective. However, both of these tests are not very widely available. They're not done in a lot of places, and so usually the diagnosis is clinically based. Another situation where you're not really sure if the patient has taken organophosphate or not, then atropine challenge test can be used. And what you do is you give the patient 1 mg of atropine, and then you observe the patient for emergence of anticholinergic symptoms. If there is rapid emergence of anticholinergic symptoms, then it's quite less likely that the patient took organophosphates. However, if there are no anticholinergic symptoms present at that time, then it's quite likely that the patient has organophosphate toxicity, and the acetylcholinesterase enzyme is blocked, and hence the atropine is unable to exert its effects. For treatment of organophosphate poisoning, the first and the foremost thing is to maintain the airway of the patient. Like I told before, that there's going to be a lot of broncholia, there's going to be a lot of secretions in the chest, and that's going to cause the patient to have respiratory distress. So airway maintenance is very important. Patients with a low GCS, with excessive chest secretions, or patients who are unable to maintain their airway, patients who are not maintaining their oxygen saturations, or patients who are in respiratory distress or insufficiency, a low threshold for tracheal intubation must be kept. If the patient has skin exposure or exposure to their clothes, then decontamination must be carried out. But as far as gastric lavage is concerned, a lot of clinicians actually say that it's not really needed. However, if the patient presents within 1 hour of ingesting or with an exposure of the organophosphate, gastric lavage can be done. The agent of choice is charcoal, and it's given at a dose of 1 gram per kg with a maximum dose of 50 grams. Once the airway of the patient is secured, the next step is to give the patient atropine. Atropine is the antidote in the organophosphate poisoning. It competes with acetylcholine at the neurosynaptic junctions, and it replaces it, thereby preventing the excess cholinergic activation of the neurons. So atropine is given in a dose of 1 to 5 mg IV or IM every 3 to 5 minutes. We keep on repeating these boluses and can even double the dose of the atropine if there is no effect noted. And our ultimate end goal, our therapeutic goal, is to reverse all of the muscarinic signs, and the most important endpoint actually is the reversal of the respiratory secretions, that the airways are cleared. That is the ultimate goal of treating an organophosphate poisoning. And we keep on repeating the atropine doses even to the effect of hundreds of milligrams until this therapeutic endpoint is achieved. Tachycardia and mydriasis are not the endpoint, and they should not distract you from repeating the atropine if there is ongoing respiratory secretions, because the tachycardia, it can be because of a lot of other things as well. It may be because of dehydration, it may be because of hypoxia, and it even may be because of pralidoxime, this transient sympathetic activation, and that can also cause tachycardia. So don't let that distract you. Remember, the end point is clearance of bronchial secretions, and if the patient has mild organophosphate poisoning, then reversal of muscarinic symptoms would be a reasonable target. In moderate to severe organophosphate poisoning, once the therapeutic endpoint has been achieved, a continuous infusion of atropine may be given. It's given at a dose of 10 to 20% of the dose which was required to achieve the therapeutic response. That means that if you gave a patient 10 milligram of atropine to clear the respiratory secretions, then you can give them an infusion of 1 milligram per hour, which would be 10% of 10 milligram. This infusion is continued until the patient develops complete recovery, and in the meantime, the rate of the infusion can be titrated according to the clinical response. We are aiming for a systolic blood pressure of more than 80, a heart rate of more than 80 beats per minute, pupils which are not pinpoint, and of course, a chest which is clear to auscultation. At the same time, we need to avoid the anticholinergic symptoms of atropine, like increased temperature or pyrexia, psychosis or confusion, and complete dryness like urinary retention or absence of bowel sounds. While atropine will reverse the cholinergic symptoms of the organophosphates, the nicotinic symptoms and the neuromuscular disturbances would be addressed by pralidoxime. It is a cholinesterase reactivating agent, and it should not be given alone. It should be given in conjunction with atropine. Organophosphate compounds bind with the acetylcholine esterase enzyme and render it dysfunctional. When pralidoxime is given, it displaces this acetylcholine esterase and binds to the organophosphate compound instead. But if more than 24 hours have passed, then the organophosphate acetylcholine esterase bond, it goes through a conformational change and it becomes irreversible. So now pralidoxime would not be able to break this bond. Hence, there would be no therapeutic benefit of giving pralidoxime after this process of aging has occurred. But as a rule, we give pralidoxime to all patients of organophosphate poisoning who present with muscarinic symptoms or who present with symptoms of neuromuscular toxicity. So basically, it should be given to every patient of organophosphate poisoning. It's given at a dose of 30 milligrams per kg with a maximum dose of 2 grams. It's given over 30 minutes in an IV bolus, and the reason it's given a little bit slowly is to prevent the cardiotoxic effects. Once you've given a bolus, then redoxim is continued in an infusion at a rate of 8 to 10 milligrams per kg per hour. And this can go on for even a few days until the patient is completely recovered. Next step of management is to give IV hydration to the patient to prevent dehydration and tachycardia. And epinephrine may be given in some patients if their heart rate fails to improve with atropine doses. However, there is no mortality benefit noted in any of the case trials, so the indication for epinephrine would be the same as for symptomatic bradycardia. In case of seizures, diazepam may be given up to a dose of 10 milligrams, but phenytoin would be absolutely contraindicated in this situation. Cardiac toxicity will be managed as the complications arise. For example, if there are arrhythmias, depending on the type, the management would vary according to that. As a summary, if there is history of poisoning, you first do the ABCDE management, then decontamination of the skin and clothes, do the gastric lavage if the patient has presented within an hour, and then you assess if the patient has mild symptoms or severe symptoms. If the symptoms are mild, then you can observe the patient for development of any muscarinic toxicity or any CNS adverse effects or any neuromuscular weakness. If any of these develop, then or if the patient has presented with severe symptoms, then we give injection atropine in incremental doses until the therapeutic response of clearance of respiratory secretion is achieved, and we also give injection pralidoxime first as a bolus and then in a continuous infusion. If the patient remains stable for the 12 hours, they can be discharged home with follow-up in psychiatry and then reviewed later. If the patient has severe symptoms and we have given atropine and pralidoxime, we keep on reviewing the patient until there is complete recovery, and then we can decide about stopping the infusions. So I hope you enjoyed this session and you learned something new.